Thank you very much. Thank you very much, Sandeepana. And I thank the Hill Country Society, Clinical Society for giving me the opportunity. I think they're not working, right? Okay, thank you. Yeah, it's a pleasure to be here, and I hope more people will attend this. Right, so we are going to talk about this. This is the topic, understanding backache. So, very common clinical scenario. Say, for instance, ක්ලිනික් එකට එනවා ගුණවතී අම්මා. අම්මේ මොකද අමාරුව? අනේ මහත්තයෝ මේ කොන්දේ අමාරුව දැන් කාලයක් තිස්සේ කිසිම ගුණයක් නැහැ. මම ડોක්ටර්ස්ට කීප දෙනෙක් බැලුවා මහත්තයෝ ආයුර්වේදයටත් ගියා. නුවර ලොකු මහත්තයෙක්වත් බැලුවා තාම ගුණයක් නැහැ මහත්තයෝ. එහෙම දැම්මා. කොච්චර කාලෙද මේ අමාරුව? දැන් අවුරුදු 10ක් විතර වෙනවා මහත්තයෝ. මට ඇවිද ගන්න බැරි වේද මහත්තයෝ? So this is a very common conversation in our clinics. Long-standing helpless people coming for asking for help. So why are we talking about this? Because it is one of the commonest visits to your practices as medical professionals if you're into seeing patients, right? And about 2/3 of the population will get affected at some stage in their lives. So we are talking about a massive number of people who we can help if we know what's going on, and it is the commonest pain syndrome. So today we are going to cover, I'm hoping to cover, these are the objectives, to review the evaluation and the differential diagnosis of back pain. Now, as you know, there are so many causes, 1001 causes, but I am going to focus on the most common causes that are of clinical relevance to all of us or you, and then discuss the etiologies of back pain, and lastly the modalities of treatment. Now, Gunawati Achi was not treated adequately, that is why she is still going from pillar to post, coming to ending up in my clinic and your clinic as well. So basics are important. The anatomy of the spine. Now in medical school you will remember we learnt about the upper limb, lower limb, thorax, abdomen, then the head and neck, but nowhere were we taught about the spine or the back. So this is part of the reason why there is so much of mystery behind backache, because we don't know the structures, we are not familiar with the structures, right? Then we are going to talk a little bit about the pathology, what goes wrong in these structures leading to backache, and we broadly classify, because once you classify it, it's a little bit much more easier to help the patient and for us, for our understanding as well. And yes, treatment is all important. So yeah, so that is the spine. Now take your time now, because we don't see this often. There you go. So it's a very complex pillar-like structure supported by ligaments and muscles. So look at this picture. It's quite a crowded picture, isn't it? It's not just a stack of bones. There are quite a few ligaments. There's anterior longitudinal ligament, and you can see the size of the nerves. This is real time from the Grant's atlas, right? So this is the real size of the structures are depicted in this picture. So quite significantly large nerves, and these nerves come from what we call neural foramina, where they exit under the pedicle of the vertebrae above and above the pedicle of the one below. So there is a confined little space, and just behind that is what we call the facet joint, the joint between the articular surfaces between the two vertebrae. So put this all into your heads, right? These are the structures which will be very important for us to understand. And the same thing from behind, this is what we call the laminae, the arch, the spinous process, and the two neural arch. When you take it off, you do a laminectomy. Anyway, so and you see all these ligaments, right? So these ligaments are thick collagenous tissue, layers and layers of thick collagenous tissue which have not a great blood supply. So these can get sprained, torn, and those collagen sheets can be injured. So it's very important to understand the large number of ligaments that we have in the back, as well as the other structures. We have what we call the interspinous ligaments and so many other ligaments. We have the nerves and we have the bones. This is what we have in the spine. Ligaments, nerves, and the disc, right? So this is what will be the reason for our trouble, right? Next picture, same thing, just repeat because it's important to understand this, right? Look at this, absorb this. Look at the space that the nerve has to come out. If there are things going wrong with the disc or the facet joints, these nerves will get compromised, right? And here is this important joint, the facet joint. A joint that, again, we have heard about it, but we haven't really, looked into it. So that is a facet joint between the upper vertebrae and the lower vertebrae. These are synovial joints, just like your knee joint. So just like the knee joint, when they also can undergo wear and tear. Just like the knee joint, you can have osteophytes, you can have excess fluid, you can have capsular disruption, and just like in bad knee arthritis, you can have subluxation of the joint. So this is a very important two joints in the facet. So that is the anatomy that is very important to us. Then there is a cross section of the spine. Again, I want you to appreciate the space for the neural elements. This is called the spinal canal. We have the two pedicles, bony pedicles, and the arch, which is the laminae, which is basically a bony, hard structure containing the nerves. And it's a very limited space. So if something comes into this space, or something hypertrophies or something bulges into this space, we are going to have problems. Because it's a tight compartment, basically a bony compartment, and the soft tissue can easily make not enough space for the important neural structures. This is not the lumbar spine, by the way, right? You can see the articular surfaces for the ribs. This one. So when you're talking about backache, this is of all importance. This fantastic structure called the intervertebral disc. So this, again, something that we are not very familiar with. So it has, as you know, probably you know, there are two parts. There's a jelly kind of like a shock absorbing thing called the nucleus pulposus and the annulus fibrosus. Basically, layers and layers of thick collagen arranged in layers, longitudinal, oblique, so that they are there for a purpose. What is the purpose? The purpose of this one is very easy to understand. It is to resist axial loading. If you are jumping from a height, if you are carrying a weight, that will be like a sponge, shock absorber. This one, the annulus fibrous, all this thick collagen, that is there to resist torsional loads, right? So turning, bending, all that will be resisted by the annulus fibrosus. And yes, pain, as you know, is generated from nerves. So this whole disc does have a nerve supply, right? We have the nerve roots coming like that, and from the anterior horn you have nerves going and supplying the disc and generating pain and letting us know that there's a problem, and also here nerves around the facet joints. So these are the things that we need to be aware of when we are treating our patients. So that is the anatomy that is important for us to understand this problem of backache. Okay, you can't there's always room for more and more anatomy, right? So these are normal disc, degenerated disc. The normal disc, see the nice bulging jelly and the nucleus fibrosis. With age, all of us will have dehydration of the nucleus pulposus. That will become thinner. The shock absorbing effect becomes less, right? So when you are young, like all of us, might be like this, right? But as age catches up, what happens is the disc height decreases. When the disc height decreases, when that decreases, what will happen? There will be increased load on the facet joints, because because there is, it tends to collapse from the front. These posterior elements will have to bear the load, right? As things go on, there is a bulging disc, and then you have a disc prolapse. Because of a radial sort of tear in some of the annular fibers, you have this jelly pushed out and compressing the nerve and causing problems. As things get worse, you have this. As we go down, you have this. Just pure osteophytes, no disc, lots of degenerative things going on in the facet joint. So that is our basically the lower back anatomy, and how we are going to talk about is going to get relevant. A little bit further down, the back is connected to our lower limbs with through the sacroiliac joint. Extremely important and often ignored. So the sacroiliac joint, you can imagine, transmits all this load, like when you run, jump, whatever, right? So massive loads go through this. So that, for the very reason, these joints don't really move much. If they started moving, we'll have trouble, right? They move about 2 or 3 degrees. But if can you remember those massive ligaments holding everything together? See these ones. If there's a small problem or disruption in those, or there is inadequate muscle stabilization of the sacroiliac joint, we will have problems. And the problems can be quite debilitating, because all these large nerves go very close to the sacroiliac joint. You have the L5, S1, L4 all going very close to the S1, and you get symptoms as a result of that. You have muscles around it like this. It's very important to know all this and how we can use them to help our patients. We have the massive gluteus max, rectus spinae, and the piriformis, all very close and supporting the sacroiliac joint. Apart from this, of course, we have the core muscles, no? The obliques, the internal and external obliques, the transversus abdominis muscles are here, and as well as the big large muscle like that, the lat dorsi there. All of that is going to give us stability. So the causes can be basically divided, for the convenience sake, into mechanical, non-mechanical, and visceral pain causing backache. So this Archie who came to clinic probably has most likely this, because the majority of them have that, and she's been having this for 10 years, unlikely to be non-mechanical sort of pain. But non-mechanical, being the 1%, is the 1% that we generally exclude first off by doing the blood tests and so on. So what are these non-mechanical spinal pain? It's quite important. We are talking about malignancies, blood malignancies, infections, and very importantly also inflammatory arthritis. These are non-mechanical causes of back pain, which of course you need to understand accounts for only about 1% of the reasons why we get backache. So easily we can exclude that 1%. You do a full blood series and you can understand, and that is that, right? But very important, because it's treatable. And of course we have the visceral, again a non-spinal cause of backache, basically referred pain. You get pain referred from all the retroperitoneal organs. We are talking about the kidneys, the ureters, the abdominal aorta, aortic aneurysms, all of this, or the pancreas, all of that can present with severe backache. And also we get backache referred from the pelvic organs, endometriosis, pelvic inflammatory disease, prostatitis, and so on. And very common is depression as a cause of backache. People, they complain of backache, but when you do a physical exam, when you take a history, there's nothing, fitting, and you have got to think about depression, right? That is a very common cause of, well, not a very common, one of the causes of backache. So majority, then like this Archie, will be having this mechanical cause. So I'm going to ask you, because you are hungry, I'm sorry, you are going to fall asleep, I'll ask questions. What are the mechanical causes of backache? Mechanical causes. Now I showed you all the possible things can give rise to mechanical causes of backache, isn't it? So like what? You have facet joint, disc, nerve. So we have the common easy one, herniated disc, mechanical cause because of a tear in the annulus. We have this, for everybody, as we age, we will have disc degeneration. All of us will have, right? And facet joint dysfunction. Ligament injuries. I showed you those interspinous ligaments, that is to hold it, to prevent bending. So if you bend with a load, that ligament is going to give way. So that's basically ligament injury. Layers of collagen have got ruptured. Sacroillititis, another cause. Spondylolysis. What is spondylolysis? I don't know whether you know. Spondylolysis is when there is a fracture or a defect in the pars interarticularis. Big word. There's another slide. I will show you the exact anatomy of that. So then we have spondylolisthesis. Listhesis where for some reason, I will tell you the reasons, where one vertebrae slides on top of the other forward. And canal stenosis. These are all mechanical causes of low back pain. Now all these ones in red, why are they in red and these guys are in black? Because all of this, spondylolisthesis, canal stenosis, facet joint dysfunction, this falls into a spectrum of disease. This falls into a spectrum of disease, which basically is this: degenerative disease, DDD. And I will talk to you more about it, right? And that will be somewhat, I think, new knowledge. Ligament injuries, nothing to do with the disc. Sacroillititis has nothing to do with the disc. Spondylolysis has nothing to do with the disc. Okay, so everything else is connected to degenerative disc disorder. Now this slide, try to absorb, is very important. Now all these problems, these mechanical problems, are age sort of related. Not everyone gets everything at the same age, right? So in the early, when you are young, up to 20 and then 30s, 40s, in this young age, you have these ligament injuries, ligament tears, ligament sprains. Those are interchangeable words, right? And you get these past defects. I'm not going to talk much about that. These are congenital problems which show up later. Then you have this annular tears, this herniation of the disc. Also when you are young, because to herniate you need to have a bulging nucleus pulposus, right? And then a little bit later, from 40 to 60, the commonest thing is facet joint arthritis. You know, the facet joints that we just showed you. Along with that, from 40 onwards up to 60, 70, and later on, more common in the 70s, 80s is listhesis, the slipping of vertebrae on one top of the other as a result of the degenerative processes. And also in that late age group, you have canal stenosis, degenerative scoliosis, and so on. So this slide will basically tells us when we get in our lives these problems, right, of mechanical backache. So we are going back to the herniated thing. So what is sciatica? Sciatica is a constellation of, basically it's a set of symptoms including pain, right, caused by either compression or irritation of the sciatic nerve or its roots. So it's not just pure compression. It's not just compression by a disc, it can be irritation. What is nerve irritation called? If the nerve gets inflamed due to irritation, that is called radiculitis. You can get a radiculitis, right? And compression, so the signs of eliciting sciatica, right? The patient tells you that there's pain running right down to the ankle, and when you do a straight leg raise, that is limited because of pain. And you can do a provocative test where you raise the leg and then increase the dorsiflexion so that the stretch becomes more. That's called the Lesage sign. Or you can put a popliteal pressure in the popliteal fossa to stretch the nerve again, the bowstring sign. All these things will tell us that yes, the patient has sciatica. What are the reasons? One could be compression, other could be inflammation of the nerve. So the disc prolapse, the symptoms that you get will depend on where the disc is prolapsing. Usually it tends to prolapse from the side, from the lateral aspect of the disc. Sometimes it can prolapse centrally. So the symptoms will be different. Here you will get a nerve root radiculopathy like pain. SLRT will be positive. Here, of course, as you can see, there is no nerve root compression. You won't get SLRT positivity. The legs will be fine, but this is a very serious condition, the chorda equina condition, where the S1 to 3 nerve roots are getting compressed. You are getting bladder bowel compromise. You are getting incontinent as a result of these nerves getting injured or compressed, right? So whenever you suspect a lumbar disc prolapse, extremely important to exclude a chord equina. So you have to do the sensory examination of the lower limbs, especially the buttock region, ask for any altered sensation, and if there is, then go on to do a rectal examination as well, check for the bladder. These are easily missed, right? And if you miss, it's a disaster because it's going to be a lifelong hell for the patient after you give him, or not that you give, but after you miss a thing like a chord equina where you are going to leave the patient incontinent for bladder and bowel for life. Right? As you probably know, the most important site is L4, L5, or the most common 5, causes mechanical as well as a very severe chemical irritation. Now this nucleus pulposus, as you remember, was formed from the ectoderm, even the neural tube during embryology. It has nothing to do with the blood system. So it is basically immune naive. When the immune system says hello to the nucleus pulposus, it's like, I've never seen you, you're like a terrorist. So massive immune reaction goes on when the nucleus pulposus bulges out and touches the nerve and bulges out of its containment. So there's massive chemical irritation as to that because immunogenic reaction. That's why it's very important to give anti-inflammatories when they have this problem. They present with unrelenting pain, not like our Archie, right? Paresthesia and myotomal weakness all come in the picture, right? So what shall we do? You do a proper examination, and if you do a proper examination you find that there is like a neurological deficit, then you're thinking about if there's a gross deficit and it's not getting better, then you have to think about surgery, right? Otherwise, by and large, can be managed conservatively because all these prolapse discs that you saw the picture of, they will resolve back into the body because the body also has its way of dealing with things without needing surgeons, right? So they will resolve and the symptoms will settle without surgery. So, but the presence of a persistent worsening pain and the failure of conservative management means they will benefit from surgery. Surgery again has its pros and cons. Yes, they will return to work faster, better functional outcome. But what's the downside? What's the downside of doing a discectomy? You're taking away that cushion, right? You're taking away the cushion and you're promoting loading of the facet joints. You're kind of, kickstarting the degenerative process if you take a lot of disc material out, right? So before we go, sorry, I missed this one, conservative treatment. What are you going to do? So as I said, anti-inflammatory is very important, antispasmodic because they get the sciatic tilt because of disc prolapses. Positioning is something that you can do. People recommend putting patients on their bellies and getting them to extend their backs. Thought to help, but they say it causes shifting of the pain or centralizing of the pain. Now sciatica is back pain plus leg pain. Leg pain is actually worse than the back pain. So when you do this sort of stuff, when you ask the patient to extend the spine, the pain basically shifts to the back. So some people promote this, but I do not. So then you have the physiotherapy department helping with things like nerve stimulation, heat therapy, massage. Acupuncture is a good thing to relieve pain. And taping of course not in the acute setting, but as the pain settles down, you can put tapes to help prevent flexion and to help with that. Traction, what about traction? Traction is good. As you can remember, I showed you the picture where the nerve exits from that small neural foramen. If you put a bit of traction, yes, it will give a little bit of increased space, but at the cost of keeping the patient bedbound. So that's not ideal, right? So it used to be practiced those days, but not anymore, right? And then we have this fantastic thing that the anesthetists help us with, epidural injections. If you can remember the slide where all those nerves, I showed you how they supply the disc, how they supply the articular surfaces, the facet joints. Once you give epidural, all those nerves get beautifully blocked and the patient is happy again, and you can start on rehabilitation by giving that. So it's extremely good. What else can you do for a disc prolapse? So this is, I'm highlighting the things that we tend to do, or I would rather recommend. Not everything, right? Yeah. So conservative treatment. So surgical management, we just told you, well, we can go in and take it out. Those days we used to put a big cut. Now you can do it like minimally invasive, like a small, like 2 centimeter cut. We can do the disc. But doing the discectomy is not the thing, because as I said, even if you do it or not, they are going to improve. It's a matter of time. So if you want to really get back to work fast, yes, there is a place. If there is neurological deficit, yes, there is a place. But there is a downside. There are issues with taking your disc out. 33% they say in America are not happy with the surgery, after surgery, and 19% need to do repeat surgery. As I was saying, if you take too much of the disc material out, you are going to overload the facet joints. That is going to kickstart that cascade of events that I am going to talk to you about very soon. Or if you take too little out, you will get a re-herniation. So you go for re-surgery, right? So that's also not good. So it's a bit of a dilemma. So to address that, now surgeons are doing or are trying it out, disc replacement. Now I just met a Australian surgeon recently at our sessions. They promote the use of using a silicon bulb, inflatable silicon bulb. They have, after many years of research, of 10, 20 watt, so to replace the functions of the disc, because now we understand how important it is in the whole spinal mechanics, right? So that is there. So that is of course not standard treatment, okay, still getting trial. So what happens? Okay, that is about disc prolapse. That can present acutely in a young child, a young person, or it can be just, small circumferential tears of the annulus fibrosis. And disc height reduces when the nucleus pulposus height, the jelly, is absorbed, right? So what happens, it's like a tire, right? It's like a tire where there's a nice canvas out and the inside is jelly. When the annulus when the jelly is less, what happens is the annulus, there is more room for the annulus it becomes a bit lax, right? The annulus fibrosis, if you can imagine, when the inside, it's like a tire deflating, when the nucleus, then the jelly goes off with age, it's like a tire deflating. Now, because the tire is deflated, it's a bit more lax, and it allows a bit more movement in the spine, leading to this. This is probably what our Archie had when she came to clinic. Degenerative disc disease, leading to symptoms like this. Basically, there's pain with movement, sitting, standing, relieved by lying down. There's a bit of tenderness. They complain of locking. When you especially bend and try to get up, you feel locking or giving way. So that is basically a phase of that degenerative disc disease. And when you examine them, basically they are normal. There's no neurology, there's no SLRT. Sacroiliac joints are fine. Everything is fine. They may have a bit of tenderness when you palpate the spine and the paraspinal region. So this is what I want to talk to you about most. This is the important concept of degenerative disc disease cascade. This was explained and the concept put forward by these wonderful guys, Kirkcaldy and Willis, two spine surgeons, I believe, back in the 90s. So they describe for all of us, we go through these phases regarding our disc facet complex. First phase during the early part is dysfunctional phase, then instability, and then stabilization, right? So dysfunctional phase is where there are small tears in the annulus fibrosis, or there is synovitis in the little facet joints, and you get like on and off back pain. Or yes, with a herniated disc, it's not on and off back pain. As it progresses further, you get the instability phase. I will explain all, right? So just keep in mind dysfunction, instability, and stabilization phase. Stabilization phase is the last phase, the latter part of life, 70, 80. That is when the stabilization phase sets in. Then you are presented with things like canal stenosis, right? Now to understand this, just I'm reiterating or repeating myself. So we have, as I said, the two spine segments are held together by the disc complex as well as the facet joint. These are the only things that it's like a tripod. The disc in front and two facet joints from the back. It's like a tripod. The tripod mechanism is what holds the spine segments together. The three joint complex. So the disc is also considered a joint. Three joint complex model of degenerative disc disease. So what happens is, as the disc height, as I said, decreases. When that decreases, we know the annulus the fibers of the annulus or the tire, they become a bit lax. When they become lax, they allow a bit of more axial rotation than is ideal for the spine. That basically leads to posterior capsules getting greater mechanical loads and greater mechanical demand, leading to metaplasia. This is how you get the osteophytes. Metaplasia is what used to be cartilaginous or ligamentous turns into bone. The body's way of trying to compensate for the instability caused by the extra load and the shearing forces brought upon by these degenerative processes. Right, there you go. So that's a good synovial joint. This is what happens as the disc resorbs or degenerates. These are loaded and these give pain, these give pain. That's what happens. Okay. Same thing, much more clearer and comprehensive. These are the three stages, right? First stage is the dysfunction state. When you are young, you get with disc herniation. So in the what you call intervertebral disc, you get these tears, radial tears leading to herniation. In the facet joints, I said nothing much is going on, just a bit of synovitis, a little bit of degeneration, nothing much, like early wear and tear of the knee. Right here, as you're like in your 40s, 50s, 60s, it becomes a bit more unstable because there's more internal disruption of the disc. The disc is resorbed, as I said. There is more movement, subluxation, things. There is unnecessary movement in the spine when we from 40, 50, 60. That period of life, because of the degenerative process, is a bit unstable. That's an unstable phase. Then the body, after forming osteophytes, the ligaments thicken, the capsule of the facet joint thickens, everything thickens. Why? Because the body has decided now, as age comes on, to stabilize the whole thing by itself, by thickening the ligaments, by thickening everything. So osteophytes and so on. So as a result of that, that little canal which held the the neural elements can become stenosed. So that leads the final stage. In the final phase of stabilization, patients will present to us with things like spinal canal stenosis and spondylosis of multiple levels. So this is at a glance basically everything that goes on in the spine, non-mechanical causes of back pain, all explained in one slide. Right, so let's try to treat this. So first of all, we need to understand, so for middle-aged people, 40 onwards, 40, 50, 60, it's not just the inflammation, there's instability of these joints and inflammation. So we have to target both. What happens to this arch who came to the clinic is most likely either only one part was targeted. Either somebody gave just anti-inflammatories or somebody forgot about need to stabilize the spine, or to do you have to do both. You have to do a multimodal approach to help these patients, right? Especially bearing in mind those two problems. So anti-inflammatory is obvious, muscle relaxation is obvious, just like with a herniated thing, TENS, massage, heat therapy, back and core strengthening. You can use corsets for the short term because they have got a problem, they have instability, they don't have enough muscle support to hold things together. For a short term, you can give, until things get better, a little corset, right? Weight reduction helps. How does weight reduction help? Now we have the spine standing erect like this. If you have a protruding belly, that is all pulling on the spine, and the spine has to keep it up. So that means your facet joints are loaded, your back is loaded. All of that will reduce when you reduce weight. And also in that little canal you have epidural fat, you have all this, even those will, you can theoretically say that they will also reduce, right? If you have a significant weight reduction, people even with canal stenosis will benefit. Smoking doesn't help, right? So apart from all that, we can also do facet joint injections, because the facet joint is the problematic area. We can go directly there and inject the facet joint. I told this earlier also. Or you can give epidural injection. It will just anesthetize all the nerves that are giving pain. So temporary excellent pain relief, right? Temporary as in it affects about 2-3 months, you can get good relief, right? So that's how we do. You do it in the theater under C-arm, look at the facet joint and inject directly into the facet joint, and that gives a lot of relief to patients. Just like you inject a knee joint, they are massively relieved of their pain. Right. So this is the X-ray of a gentleman who came to clinic the other day. So If you're in, yeah, so what do you think is going on? He's a farmer who complained of backache. What stage do you think this is? This is the, yeah, age itself will tell us it is in the instability phase. Dysfunction, instability, stabilization. This is not, this is instability. Can you see the, if you draw a line along the posterior part, this has shifted. There's a listhesis. Listhesis of L4 over L5. And plus, here these are the facet joints on your X-ray. Here that's the facet joint. See, you can see that. That's the facet joint. That you can see the line there. So you can see that's quite degenerate. It's not a nice facet joint. And as you come further down, quite bad. Probably the joint is quite badly disrupted. That is the very reason why this is slipping forward, because there's so much of movement, subluxation allowing this to happen. So yeah, treating this patient, we can use all those modalities. If all fail, then we can go and do a laminectomy, give enough space, take off this bony constriction, take it off completely, and then stabilize the spine. Core strengthening is extremely important, that we often forget. So for Archie, we ask Archie to do this. This is, what are these? This is basically strengthening the anterior abdominal musculature. Crunches, right? You have to teach your patients crunches. As in, not all the way up, because if you come all the way up, you're again flexing the spine, not ideal for the spine. Spine likes to be stable. It doesn't like excess movement at that stage of life. When you're young, when you're 20, 25, that's fine, or younger than that. And this, when you do this, you're basically hyperextension. Hyperextension means your articular, the facet joints are getting loaded. So this one, sometimes people don't tolerate because it causes pain. So this alone is good enough, core muscle strengthening. This one, we can ask the patients to do to the point where they get the pain. You never advise people to do exercises if there is pain. If there is a slightest amount of pain, that's a sign by the body that it's not going well. So you tell them, just raise your buttock just a little bit. So what this is doing is strengthening the buttock, strengthening the erector spinae muscle. These are very important to stabilize the lower back. Okay, now we come to the last or final stage, or the final phase. What happens is, here, this is what in the picture, normal, nice and spacious, enough room, but here we have hypertrophied ligaments, osteophytes, all of that coming and compromising the canal. You get what is called lumbar canal stenosis, very common in the elderly. They come and tell you things like, well, yeah, these are the reasons you get joint hypertrophy, disc protrusion, thickened ligaments, all contribute to narrowing, as well as sometimes it really slips forward. That also, if the arch is intact, is going to cause a severe degree of canal stenosis. So they come and symptoms and signs of canal stenosis. They come a bit stooped, they walk, because that gives a bit of flexion to the spine and gives enough room, slightly alleviates their problems. Cramping in the calves with walking, requiring frequent short rests. They have what is called neurogenic claudication. They take a few steps or they walk 10 meters, they have to stop. They usually stop and sit down so that they flex the spine to relieve their symptoms. Not like what you call vascular claudication, where you don't have to do that, right? So for them, for canal stenosis, again you do a multimodal approach. You basically, again, the anterior abdominal wall strengthening is going to help because it's going to keep the spine a bit flexed. But surgery is very useful. You can do it if, you know, if the back and leg pain limits normal activity or impairs the quality of life, progressive deficits develop, and yes, it can affect the bladder and bowel as well. So yes, canal stenosis is easily addressed by doing a laminectomy. You just take the laminae from the posterior part of the spine and then the structures are free again. Repeating again, so options for, apart from the conservative, the surgical options would be, for a disc herniation in the early phase, you can do a discectomy, but you don't have to, as I said. Most of the time you don't have to. Destabilization phase, the common phase in the 40s, 50s, when they have all this excess motion. If all those conservative things don't help, we can offer them a laminectomy with fusion. Just doing a laminectomy is not going to help because they have too much movement in the spine. So you fuse it as well. For the elderly, the old people who have already got osteophytes, everything is basically like cemented, you can just do a laminectomy and get away sometimes. You don't have to do a fusion because it's quite stiff and cemented there, right? This one. So we went through those very common three causes. This print is horrible. Sorry. Sacroilitis, very common. How do they present? They present, again, they can have one-sided lower back pain radiating down the leg sometimes. Why does sacroilitis cause radiating pain down the leg? Because of the inflammation, you get what is called the radiculitis, because all the nerves are very close to it, L5, S1, L4, because they go basically on top of this thing. So they will complain of pain just like sciatica when it's severe. You can't do a straight leg brace. This is quite rare though. I mean, it's not very common. Otherwise, they will just complain of pain coming to the groin region by the because the L4 is irritated. L3 and L4 are irritated. You should come to the anterior thigh and so on. Sorry, I mean that's really bad, that slide. Okay, so that is what I was just telling. So see how closely the nerves are to the joint. So no wonder you get a radiculitis, and that is what we see when we inject the joint also. These nerves get affected by the lignocaine and they get a bit of numbness in the leg because it's so very closely related. So the physical exam of sacroilitis is a condition which is very underdiagnosed, right? SLR will be negative except the final 80-90 degrees. When severe, as I said, it can mimic like a true sciatica. Patrick's test is where you flex and externally rotate so that it's a provocative test. You provoke you load the sacroiliac joints and they will complain of the pain that they have being worse. And you can palpate and there will be tenderness in the sacroiliac joint region. You can also look for interspinous ligament injury and pathologies like that. So this is just another picture to remind you what it's like. So we have nice muscles around which we can use to help stabilize this problem. Sacroilitis is very important. Young people can present because of inflammatory pathologies with sacroilitis like ankylosing spondylitis and so many inflammatory pathologies. So you have to be aware. You can't just say everything is because of instability causing sacroilitis, right? But in our case, in our country, very much the case, because we are not the fittest people, I think. Our abdominal, the core muscles are not supporting enough, especially during childbirth, after childbirth, very common in females to get sacroilitis because of poor muscle tone, leading to unnecessary movement in the SI joint. So how do you treat it? So you can cure it, right? Once you understand the problem. You have to stabilize the joint and help with the pain. So a belt is useful because the ligaments may have got injured. A belt will support the ligaments and give it some time to heal. Because the muscles are not strong enough, it will also do the work of the muscles. Again, anti-inflammatories and analgesics. Joint injections are very useful when it's severe and they can get on to the rehab or the core strengthening programs earlier. If all of this don't work, some surgeons recommend sacroiliac joint fusions, right? So it's a big thing in some countries. It can be done, but the thing is, yeah, it's known to have other problems. Once you fuse one joint, you can very well imagine just by fusing a joint in a patient, the backache is not going to go away, right? So we can generally manage without the fusion with doing all the other things, right? So strengthening exercises for the SI joint are very, 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 very important. So you have to understand, for the vast majority, it's a problem with increased movement in the SI joint. So we are going to focus on decreasing that stress on the joint and strengthening the muscles that surround it. And you can do this by strengthening your gluteal, the core muscles and the lat dorsi. So these are the things that we recommend our patients to do. The exercise called, I show you, hip bridge, abdominal crunch, the plank, I'm sure you know, most of you, and the side plank. Side plank, I don't think Archie can manage, but people who can manage, young postpartum mothers, when they of course can be promoted and encouraged to do all those things to strengthen the core. There you go. That's the hip bridge. That's the crunch. For sacroiliitis especially is useful. You can do the plank. And this one. This is basically recruiting the adductors. You can ask them to press on a ball and basically it helps with the SI joint. Some people say they get kind of fast relief with this. But so basically I recommend all four. Pushing the knees together and pushing the knees apart. When you push the knees apart or rather force them apart against resistance with a band, you're recruiting your piriformis, right? So you're getting everybody who can help the SI joint, the glutes, the core, the piriformis, the the adductors, all of them to come and help with the problem, right? But of course you can't do this in the acute setting. If there's too much pain, you have to first let the pain settle down, wear a belt, give injections, take some time, give steroids. We do use like dexamethasone, very useful, and so on. So basically we have covered quite a lot of our mechanical causes of backache, if you remember, right? I won't go back. So we covered disc prolapse, degenerative disc prolapse, disease, facet joint arthropathy, canal stenosis, spondylolisthesis to some extent, and this acroiliitis. These are the very, very common things that we see in our clinics. So what's this? I didn't talk about this. Anybody? No juniors? Any seniors? You all know this is all too obvious, right? So this is what the spine looks like when you take an oblique X-ray. So these are the spinous processes. These are the spinous processes. This is the laminae, and this like head is the the X-ray view when the pedicle is directly facing the X-ray, right? So this is the superior facet joint. You can nicely see this area. This is where we inject when you go in the C-arm. Superior facet joint, inferior facet joint. The area between the facet joints is called the pars interarticularis. Basically, I think in Latin, meaning the part between the two articular surfaces, right? You get a fracture of that for various reasons. It may be degenerative, it may be lytic, it may be neoplastic, it may be traumatic. And you get what is called a Scotty dog appearance on the oblique view of the spine, right? Scotty dog with the collar, that the collar is where the break is, right? These things by and large can be managed conservatively. But if you can imagine, if both of these break on this side as well as on the other side, what will happen? It will give a chance for the vertebrae to slip forward, because that whole arch holding through the facet is gone. See, again the same thing in real sort of a more real picture. So this is the Scotty dog. We call this the Scotty dog, right? The Scotty dog, you can see how the Scotty dog is made. That's the Scotty dog ear, face, the neck, and that is where the fracture occurs, the pars interarticularis, right? Just for completeness sake. Okay, we are done basically. Case discussion. Accountant, 30 years, left-sided backache, radius to calf, no weakness, no history of injury, falls lifting. Can you guys wake up? What do you think is going on? Last bit. What do you think is going on? Okay, any thoughts? Any thoughts at all? What are you thinking? Huh? Sacroiliitis, yeah, very good, excellent. Yes, radiation to calf because of radiculitis. Yes, can do. Excellent, excellent. Yeah, no weakness, no history. So he's 30 years. He's a man, I did mention. So yeah, sacroiliitis is the diagnosis. So what else must you think? Young man with sacroiliitis. You must think about? No. Ankylosing spondylitis, right? You got to be aware of that, and then you order X-rays to confirm your diagnosis. Like this. 3 sets of X-rays in different stages of ankyspon, right? Here you get squaring of vertebrae, and can you see you have the shiny corner? The shiny corner is called the Romanus lesions. That is because of enthesitis, right? That gets a bit worse, and you can see little bony spurs where the annulus fibrosis becomes ossified, These are not typical osteophytes as you see in degenerative disc disease, as I was talking about. And of course, things get pretty bad. The whole spine becomes basically like a rigid bamboo. So that's it. So we have covered the common causes of backache. Any questions? Fast asleep, no questions. Right, okay, thank you. Right.